United States Department of Agriculture.
So good morning, everybody. First of all, I would like to thank the organization for having me and presenting the observed guidelines, which are guidelines for the refinement of rodent cancer models. So I'll first start with an introduction, and then I'll explain a bit more about the observed guidelines, how they were developed, which objectives we aimed for, and some of the content. And then I'll show you also how to put these guidelines into practice. I'll also talk a bit more about severity of rodent cancer model and end up, of course, with a conclusion. So in 2019, almost 1 million animals were used in cancer research in the EU. I guess that's even more in the US. And it is one of the top 4 disciplines for animals used across basic and translational research applications. So actually, there's a lot of room for refinement for these mainly rodent or mouse studies. How did all of this start? I'm a member of the ethical committee, and as a designated vet, I get a lot of questions from researchers like which humane endpoints should I use for subcutaneous tumors, but also for orthotopic tumors, and how should I score severity? And it is the task of the ethical committee, which is comparable, of course, to the AWIC in the US, to develop guidelines. And the initial or primary goal was to develop guidelines for KU Leuven, our institute. So I started looking at available guidelines. And you find a lot of institutional guidelines, mainly from US-based institutes. And then I also had a look at literature. And when you look for publications on humane endpoints or on refinement of cancer models, there's a very old paper from 1988 by Workman et al., and this has been revised in 2010, so Guidelines for the Welfare and Use of Animals in Cancer Research, and it is currently being revised also. And then there's another publication, Humane Endpoints and Cancer Research by James Wallace. Then there's there are some other papers on refinement and endpoints, but if you can see, it's specifically, for example, glioma models or a specific cell line. So the available guidelines are often too general because they specify that, for example, you can use imaging, but they don't specify how often you should image the animal. Or what I found really striking when I started this work was that you can find a lot of guidelines for subcutaneous tumors, but not so much for orthotopic tumors. Other guidelines, which I showed you in the previous slide, are really model specific, and they're not so easy to find. They're not often published in cancer journals, which of course, if researchers are looking for guidelines, these are the publications they will look for, or the journals they will look for. So there was a need for practical guidelines to refine in vivo cancer studies, which cover most models, also the orthotopic ones, and which include really specific recommendations and specific humane endpoints. So the observed guidelines, as I said, the original idea was to develop these for KU Leuven, so for our institute. But then I quickly realized that this was too much work to do by myself. So after discussing with some colleagues, we set up actually a steering committee, which consists of 12 designated vets and animal welfare officers from 9 institutes, and institutes both in academia and industry. And you can see here the different institutes that collaborated. So there are institutes from Belgium, the Netherlands, Luxembourg, from somebody from Vienna, we have people from Scotland and from France. And this work was also supported by the European PDX platform, so the patient-derived xenograft platform, and was also supported by InfraFrontier, whose mission is to improve reproducibility of animal studies. So the guidelines are based on the experience of the steering committee's members, and also on available literature. But it's not a review because there are, of course, some methods that, for example, are published, but may not be practical to use or may require specific equipment. First of all, we started by identifying 4 key objectives, and that was that they should be comprehensible for a diverse audience, so researchers, but also animal technicians and animal caretakers. We wanted them to be really practical and really precise, not saying, okay, you could use imaging, but which kind of imaging should you use? Also defining, as I said, not only volume for subcutaneous tumors, but also for other tumors. And the focus was really on refinement and reproducibility. If you have a tumor model that is maybe better for welfare for the animals, but you can not translate your results because the animal model is not good enough, then of course that makes no sense either. And it should be, we also defined that it should be applicable to a wide range of tumor models. So the observed guidelines were finally published in July, and OBSERVE stands for Oncology Best Practices, Science, Endpoints, and Refinements for In Vivo Experiments. And of course, you can read the paper and you can go through everything, but I'll guide you through some of the content. So a first chapter is on refinement during implantation or induction of tumors. Then our focus was really on the clinical consequences of the different cancer models. What can you expect when you for example, a liver tumor? Which are the clinical signs? Which are the adverse effects? And then, of course, there are refinement guidelines and refinement during tumor development. So how should you follow up your tumor, but how should you also follow up the animal? Of course, they're both linked, but we decided to make the distinction between the two just to make sure that we could put enough emphasis on both the tumor and the animal and its clinical signs. And then something about severity. So we have given guidelines to refine tumor implantation or induction of subcutaneous tumors, mammary tumors, intracerebral injections, intrapulmonary, intraabdominal, IV, hydrodynamic tail vein injection, intracardiac, intramuscular, intrabone marrow, paratibial, but also the carcinogenic models, tumor resection models, and humanized mice. And I'm going to give you the example of the mammary gland. So our guidelines say that they should preferentially be implanted in the 3rd or 4th mammary gland. And depending on the research question, a specific mammary gland can be better suited. The volume should be no more than 20 to 30 microliters. And if it's a tissue fragment, it should not exceed 3 by 3 millimeters. And also for the intraductal injection, does not necessitate cutting the teeth, which has been described. For implantation in the mammary gland, we refer to this paper by Tavera Mendoza and Brown, where they specifically explain a less invasive method for orthotopic injection in the mammary fat. For example, also for bone marrow, there is this paper by Pfeifenberger et al., who propose a refined method for injecting in the femur instead of in the tibia. And you can see here that in the full gray lines are the animals that were injected in the femur, and the dotted lines are the ones that are injected in the tibia. And you can see that they have the ones that are injected in the femur, so the refined method, are less lame, have higher grip capacity, and have a lower weight loss compared to the other ones. As I said, our main focus was really on the clinical consequences of the different model. And I know you cannot read this table, but I'll guide you through it. So what we actually did is made a table where on the left-hand side, we have the different tumor models. And on the x-axis, we have the adverse effects that can be seen. And then we put crosses for each clinical sign that can be seen in a certain tumor type. So for our adverse effects or our clinical signs, we made a distinction between general signs and specific signs. And for the general signs, we decided that these were anorexia and body weight loss, altered appearance and behavior, where you can evaluate the fur and the behavior of the animal, for example, but also if animals are hunched or not. And then also pain. And there we made a clear distinction between demonstrated pain and assumed pain. And demonstrated pain, looking at all these different papers, it is a bit sad to see that pain is almost never measured in cancer models. While we know that a lot of cancers are painful. So if researchers really looked at pain in their animals, often because they are studying cancer pain, then it is called pain demonstrated. But if it's painful in a human, we assume it's also painful in a mouse or in a rat, and then we put the cross with pain assumed. Just to really put this focus on pain in cancer because it's something that is often overlooked. So general signs, there's a lot to do about body and tumor weight. And one of the important things we wanted to highlight is also how should you determine your baseline body weight. And here's an example. If you have an 18-gram mouse that is injected with a slow-growing tumor, the animal will grow. There will be no clinical signs. But let's say the animal grows to 25 grams, and then the clinical signs start, including body weight loss. Which baseline weight should you use? Say your cutoff is 20% body weight loss, and you take 25 grams as your baseline weight, then the endpoint will be 20 grams. If you take 20% from 18 grams, it's 14.4. But if you decide the 18 gram and you calculate your body weight loss from these 18 grams, and you let, in this case, you will have 42% body weight loss if you let the animals decrease their weight until 14.4 grams. So the correct baseline weight is, of course, the 25 grams. In some cancer models, you can also have a body weight increase. There are papers describing this body weight increase as helping in defining humane endpoints. And also, we wanted to address for volume of tumors. There are some guidelines or existing guidelines that all focus on the volume of the tumor itself, and some guidelines that really go into the tumor weight versus body weight. And you can see here in this table that actually this mainly becomes an issue, assuming that 1 cubic centimeter is 1 gram for a tumor. You can see that the figures in bold, that only becomes an issue when you have really big tumors and especially in very small mice. So that should be taken into account also if you use animals that are not 18 grams and let the tumor develop bigger. And then we have this set of specific signs, which are icterus, respiratory signs, ascites, anemia, gastrointestinal signs, neurological signs, locomotor signs, urinary, and what we defined as cutaneous ulceration, because of course there are, for example, gastrointestinal tumors that can also ulcerate, but we really mean the ulceration of the tumors that are transplanted subcutaneously or in the skin. And as I said, on the left, we have the different organ systems with the different tumors. And so the idea is that a researcher can really look, okay, what can I expect in this kind of tumor? Because, of course, as one of our objectives was that it should be comprehensible for a broad audience, for each of these clinical signs, we also explained a bit more what is it and how should you assess it. And for example, why can cancer be painful? Why can it cause respiratory signs and so on? So our goal was to go into more detail about the grimaces, but really to say, okay, you can use the grimaces, you can use nest building with the correct references so that researchers know how they can assess, for example, pain. Here is another example for dyspnea or labored breathing. How can you see it? You can see it as difficult breathing, but it only often becomes visible in advanced stages of disease. And that's why we introduced, we did not invent it, we have modified it, a stress test. And this is how a stress test looks like. It's a very simple method you can use just when you want to assess. You don't need any equipment to do it. So you take the mouse, you put pressure on the xiphoid, and you see how the animal responds to that. If it gets difficulty breathing really quickly after you have applied pressure, this is an endpoint. And in the paper that was published about this, they call it a PAM test or the stress test, they were able to avoid spontaneous mortality in a lung metastasis model. For example, for neurological signs, we also included different tests, easy tests, for example, the clasping test and the kyphosis test. On the left, you see the clasping test. It's also, again, a simple test. You could, for example, do a catwalk, but not everybody has these kind of devices. So in clasping, you just lift the mouse by the tail, and a normal mouse is a score 0. And you can see a normal mouse really spreads out its hind paws, while if it has neurological issues, it will keep its paws all together. So that's really an easy to perform test, which you can include in the monitoring of the animal. On the right side, you can see the kyphosis test, and here it's the other way around in this picture. You see score 3 is a normal mouse. If you put it on a flat surface, it should elongate or take in a normal position, while if something is wrong, it will stay in this hunched position. So refinement during tumor development. So during tumor development, so we already had the during implantation or during induction of the tumor, but then the tumor develops. How can you refine that? And that's mainly by a good follow-up. So by looking at your animal, at the tumor and the mouse. So as I said, we decided to make this twofold to be able to put enough emphasis on both. So how can you follow up the tumor? Of course, you can follow up the volume and the appearance. And for volume for subcutaneous tumors, you can use the caliper. And we included also something about what is a good formula to calculate the volume of a subcutaneous tumor, but also how should you use your caliper correctly. You can see in figure B that the caliper is positioned correctly. That means that the caliper can still move over the tumor, while in figure C, it is really squeezing the tumor, and you can see this difference in millimeters. And I calculated it for, there's 100 cubic millimeter difference between B and C. But of course, volume can also, depending on the model, done by imaging, palpation, or blood sampling. There's a big table on this follow-up of the tumor in the paper. So we basically describe also the frequency. And what I think is really new is that we also included criteria for killing solely based on the tumor. And I'm going to show you some of them. For example, for the subcutaneous mammary and skin tumor, we recommend the criteria for killing solely based on the tumor, 2 cubic centimeters, or if it touches the cage floor, or if it ulcerates. And then, for example, for the orthotopic tumors, for the lung, no more than 50% of total lung volume. For the abdominal tumors, no more than 1.5 cubic centimeters. For bone and muscle tumors, maximum 10 millimeters of tumor diameter. And for the brain, no more than 25% of the total volume. Then follow-up of the mouse. So we had follow-up of the tumor and then follow-up of the mouse based on clinical signs. We have developed a set of monitoring sheets. And we call it monitoring sheets and not score sheets because we didn't want to put numbers in there. And we wanted to be able to combine the different monitoring sheets to have a complete monitoring sheet. So it actually, you can put and combine the monitoring sheets. In the monitoring sheets, we included the clinical sign to monitor, the frequency, and also the action to take when a specific sign is seen. And this is not just killing the animal, but also some steps to, for example, increase monitoring or start doing a certain test and so on. So here you can see the general monitoring sheet with anorexia and body weight loss, hydration that should be checked, appearance and behavior, as I said, posture, fur, and activity, and then also the pain. As some models include surgery, we also developed a monitoring sheet for post-surgery, where the surgical wound should be checked to see if it doesn't open and also if it is not infected. And again, this emphasis on pain. And then there is a monitoring sheet for the respiratory signs, neurological signs, locomotor signs, and as I mentioned before, for the neurological signs, we included this crisp clasping and kyphosis test, and for the respiratory signs, we advise to use this stress test. Then for the gastrointestinal signs, urinary signs, and ascites. Why ascites? Normally, ascites should be an endpoint, but there are models where ascites is studied or where ascites is unavoidable. And we also wanted to give guidelines on how to tap and when to tap and how often to tap. And then this is the sheet for the cutaneous ulcerating tumor, where we also allow to treat the ulceration in order to be able, of course, this should always be discussed with the vet and with the researcher, but to be able to, in these cases where ulceration may be expected to, for example, irradiation, where you may, by treating the animals, maybe gain some data. So how to use these guidelines in practice? So it's a stepwise approach. If you're going to develop a model, that you first check table 1 to see which adverse effects are expected. Then check table 2 to see how you should assess these adverse effects. Then select the appropriate monitoring sheets. If surgery is involved, also include the post-surgical monitoring sheet. And then check table 3 for follow-up of the tumor. And then you're going to combine everything, and then you have a final monitoring sheet. And an example is a brain tumor model that is surgically implanted, how to follow up and define the humane endpoints. So first, define the adverse effects. So a brain tumor can give anorexia and body weight loss, altered appearance and behavior, pain, and neurological signs. And then you're going to start do your puzzle. So as it involves surgery, include the post-op monitoring sheet, the general monitoring sheet, the ones for the neurological signs, and then let's say this is done by follow-up by MRI, include the size of the tumor, and then you have one monitoring sheet. And then a bit more on severity. I don't actually really know how this is done in the US, but according to the EU directive, all animal procedures must be classified as mild, moderate, severe, or non-recovery. Non-recovery are procedures which are performed entirely under general anesthesia. Mild are procedures on animals as a result of which the animals are likely to experience short-term mild pain, suffering, or distress, or procedures with no significant impairment of the well-being or general condition of the animals. Moderate are then procedures on animals as a result of which the animals are likely to experience short-term moderate pain, suffering, or distress, or long-lasting mild pain, suffering, or distress. And then severe are, of course, those procedures where the animals may experience severe pain, suffering, or distress. When you look at these definitions, it's quite difficult to know how to classify the severity of a certain procedure or a certain model. That's why we also wanted to give some guidance on that topic. So we think that severity should be based on clinical consequences, on the tumor characteristics, and on the implantation methods, on all three. And the clinical consequences should take into account the humane endpoints, and some models automatically fall into a specific category. I'm going to give you some examples. For example, neurological signs. If you have animals with circling head tilt ataxia, but it does not prevent them to eat and drink, we would recommend to put that into mild, while if it prevents them to eat and drink, and that's one of the conditions, that's also an endpoint that can stay into moderate if you kill the animals immediately. Same for if they develop seizures or paresis paralysis. If you take appropriate action, that means killing as soon as you see that this can stay into moderate. The severe models or those models of cancer cachexia, those requiring acidic tap, studying cancer pain, and the bone tumor models. For the tumor characteristics, we decided that an uncomplicated subcutaneous tumor up to the maximum allowed size, 2 cubic centimeter, can stay into mild. If it ulcerates, and it is, of course, normally that's an endpoint, but if in the case it is allowed for some ulceration, then it goes into moderate. The other uncomplicated, and I mean uncomplicated as in not having developed one of these clinical signs, if it reaches maximum size, it can stay into moderate. And then for the implantation method, subcutaneous implantation mild, but the implantation requiring major or repetitive surgery or hydrodynamic tail vein injection moderate. So in conclusion, as I said, almost 1 million animals were used in cancer research in 2019, so there is room for refinement, and we hope that with OBSERVE, we offer practical guidelines to refine in vivo cancer studies, especially the orthotopic tumor models. I would like to thank the members of the steering committee. I would also like the members of my institute, the researchers of my institute who helped me with a lot of practical questions, and also EuropeDX and InfraFrontier. And then I would like to thank you for your attention.
USDA is an equal opportunity provider, employer, and lender.